Another 30 seconds, we are going live, sir.
Okay.
Yeah. So in another 10 seconds, we are going live.
Yes.
Yeah. So it's 3, 2, 1. We are live to the audience platform. We can start this meeting. Over to you, sir.
Yeah. So a warm good evening to one and all. Welcome, doctors, for our today's program. I am Dr. Pragadish from Sun Pharma Medical Team. On behalf of Sun Pharma, we welcome to our distinguished webinar, Essentials of Heart Failure, a special perspective on beta blockers. It's our honor to have such an esteemed audience of medical professionals joining us for the promise for this discussion today. We are privileged to host two eminent experts in the field of cardiology. Our first speaker is Dr. Andrews, Director of Cardiovascular Research at Heart Institute, University Hospital from New York. So he is an renowned cardiologist for his work in cardiology research, and he's the immediate past chair of Research Committee of Heart Failure Society of America. He also serves as an associate program director of Cardiology Fellowship Program. He worked on the risk factors outcome and clinical predictor model for patients with advanced heart failure with the goal of optimization of the management of heart failure patients. He has published more than 180 scientific articles, review text. He is the executive editor of Heart Failure, an essential clinical guide. He is recipient of multiple awards and honors, including the Delta Omega Honorary Society in Public Health, the Echo Industry Award from American Society of Echocardiography, the Outstanding Scientific Citation in Clinical and Translational Science, and the Distinguished Mentor in Department of Medicine at Emory University. He is on the Scientific Advisory Board for World Congress on Heart Disease and noteworthy reviewer for over 50 scientific journals and the editorial board member for Journal of Cardiac Failure. He was recognized by ExpertScript as the world expert in ventricular dysfunction and was a recipient of 2021 of the Stony Brook University Department of Medicine's Clinical Research Award. So we welcome you on board. It's our pleasure to have you here, sir. We have our Indian speaker, Dr. C. Raghu, sir. He is the structural heart interventional specialist from Yashoda Hospital, Secunderabad, India. He has got Srimati Kirpakaru Medical Gold Medal from Most Compassionate Resident from the AIMS, where he completed his MD General Medicine, and he has completed DM Cardiology from Nizam Institute, Hyderabad. He has awarded Sri Krishna Memorial Gold Medal for the best research work CSI AP chapter. He was awarded the best young interventional cardiologist first prize in Singapore Live, and also he was awarded Andrews Award for the best chronic total occlusion angioplasty and best peripheral vascular intervention award from 7th Asia Pacific Vascular Society. So we welcome you on board. So we will be hearing from, thank you, sir, from Dr. Andrews first on the heart failure and essential guide, and post which Dr. Raghu sir will take us on the beta blocker, the cornerstone of treatment for heart failure and Indian perspective. Sir, over to you, sir.
Well, thank you very much for the kind introduction. I'm Andreas Kalogeropoulos from Stony Brook Medicine, New York, and I will provide like a brief overview of the approach to the treatment of the patient with heart failure and reduced ejection fraction, and we will hone in on the use of beta blockers, which is a pillar of therapy in these patients as the talk progresses. And please allow me to share my screen right here.
It's visible, sir.
Okay. Is it in full presentation mode?
Yes,
Does it look
full,
okay?
Yes, a full screen as well. Thank you, sir.
Okay. And I would like this opportunity also to highlight our recent textbook together with Dr. Skopik and Dr. Butler, which covers a lot of details that we will not be able to talk about today for those who treat patients with heart failure as general cardiologists or as heart failure specialists. And this is the outline of my presentation today. Heart failure is a global problem and it's rising in prevalence worldwide in all of the countries for which we do have data. And the reason the prevalence is increasing and it is projected to increase is because the global population is aging. For example, the United States, we expect to have 50% more patients with heart failure than we have today. And the one thing is aging. The other thing is that people with heart failure live longer because of better therapy. So you have more patients living with the disease. But also another factor is that diseases that were previously leading to death are now treated, and patients are left with a damaged but functional heart. For example, Dr. Ragu here is treating patients with severe myocardial infarction. Several decades earlier, these patients were about to die, but now they do live on. However, they do have like heart damage that puts them at risk for heart failure. So these three factors in combination lead to ever increasing prevalence of patients with heart failure. And it is important to realize that when we talk about heart failure, we're talking about a disease that has multiple stages. And the reason that the American Heart Association has designed these 4 stages of heart failure is to align with other chronic non-communicable diseases and also to focus on prevention. When we talk about stage A heart failure, we're talking about people who have risk factors for heart failure like hypertension, diabetes, existing cardiovascular disease, exposure to toxic agents, for example, chemotherapy, but they have no damage on their heart. So if you look at their echoes, they would look normal. Stage B are patients who do have visible damage in the heart as a result of, for example, myocardial infarction or left ventricular hypertrophy because of long-standing hypertension or any form of impairment of the heart function, but absolutely no symptoms. Stage C heart failure, and this is where we're going to focus today, is patients who unfortunately did develop symptoms of heart failure. And from there, the patient can be stabilized or keep progressing to advanced heart failure, which unfortunately for most patients is an inevitable stage because heart failure is a progressive disease. Despite that, you think that the patient is stable on the surface. Unfortunately, the underlying pathophysiological processes do move forward, and there is disease progression, and we reach a point which we call stage D or advanced heart failure, where the standard pharmacotherapy and the usual devices do not work, and the patient needs advanced heart failure therapy, for example, left ventricular assist device or heart transplantation. And this is an outline how we approach the diagnosis of heart failure briefly. Obviously, the basis is the patient's history and science and physical examination. There is something about the electrocardiogram. There is no electrocardiogram specific for heart failure, but all teachers say there is no heart failure with normal echocardiogram either, meaning you're going to find something, but it's not specific. The other components that are important in the diagnosis of heart failure is elevated natriuretic peptides according to existing thresholds. And in fact, the European Society of Cardiology has additionally refined the thresholds for NT-proBNP on the basis of age. But this is a broad classification. At least if the patient has very low natriuretic peptide levels, it makes it very unlikely that the patient has heart failure, except for the very obese patients, because obesity causes natriuretic peptide levels to become lower. So be mindful when you're testing natriuretic peptides in an obese patient. They may be falsely low because of this issue. The other component is transthoracic echocardiography. It is very unlikely that the patient has heart failure and a normal echo. Very unlikely. You're going to find the cues of the heart failure etiology, like reduced ejection fraction or hypertrophy or valvular heart disease, or wall motion abnormalities like regional from ischemic disease on echo. And this is where it is important after you determine the cause of heart failure even broadly and look for pre-existing factors, just to classify the patient based on the heart failure on the ejection fraction presentation, the left ventricular ejection fraction. And there is a broad classification. I will explain in a second why this is important. Usually we call reduced ejection fraction less than 40%. The mid-range or mildly reduced ejection fraction is the 40 to 50% category. And we like to call preserved ejection fraction patients who have ejection fraction over 50%. Now, why is this important? Some people argue that this is like kind of an artificial definition. It is an artificial definition, but has also a solid pathophysiologic basis. Here's the reason why. Regardless of the etiology of heart failure, patients with reduced ejection fraction have a common pathophysiology. Whatever they started with, ischemic heart disease, hypertension that was untreated and led like to a ballooned out heart, primary dilated cardiomyopathy, cardiotoxicity because of chemotherapy, alcoholic cardiomyopathy. You can think any case of heart failure with reduced ejection fraction. The underlying pathophysiology that we're trying to break that vicious circle is the same, and that's why the same therapies work for all these patients. This is not the case with heart failure with preserved ejection fraction. That's why the classification based on ejection fraction or what you see on the echo is important, because you treat differently, and we'll focus on reduced ejection fraction in a second. Now, what are our goals of therapy in these patients? We have two goals of therapy: help the patients live better and help the patients live longer. And by living better mean improve the symptoms and the clinical status. We want them like to be decongested and be able to breathe freely and walk freely, have better functional capacity, obviously, and better quality of life. And we want them to live longer. There's one important key message here. If you want the patient to live longer, we have to stop and reverse the damage to the heart. And I will come to that in a second. I have put preventing admissions in the middle because this helps the patient live like better, but helps also the patient live longer. The reason is there is ample evidence that if you prevent readmissions, you improve also mortality. The reason is that there is something about admissions that worsens the patients. No, it's not like we're doing something wrong, but admissions are a marker of disease worsening. So there are many anecdotes about why patients end up like in the hospital, like they ate too much salt the day before. That's debatable. The reality is that no matter how good you treat heart failure and how careful a doctor you are, heart failure will progress, and the patient, unfortunately, will end in the hospital sooner or later. And this is a marker of disease progression. That's why you can use it to see how the patient will go. If you can prevent admissions with your therapy, this is a better sign for longevity for the patient. And we did this editorial with my excellent fellow last year, showing this important point. This is the point that I wanted to make before. If you want the patient to live longer, you have to stop or reverse the cardiac damage. And the therapies that have proven to stop or reverse cardiac damage are the therapies that are making the patient live longer. Improving the symptoms alone will not the patient live longer. Like diuretics are excellent in improving symptoms, but they will not make the patient live longer. You have to improve like the heart. All these medications that I'm showing here in this table, in mechanistic studies where they look at how does the patient do on echo, for example, they have proven that heart function improves. So if you can improve heart function, then the patient will live longer. So that's my message here. And there are currently 4 cornerstones of heart failure therapy. The first and most important in the development and importance is the beta blocker. And the beta, I will explain in a second why the beta blocker is like the most important. Then the second pillar is what we call the renin-angiotensin system inhibitors. The most modern implementation is angiotensin receptor neprilysin inhibitors. And there's only one medication in this class at this point, sacubitril valsartan, which is a better replacement for the traditional ACE inhibitors and angiotensin receptor blockers if the patient can tolerate the more hypotensive effect. And then you have mineralocorticoid receptor antagonists. The older is spironolactone, and the most newer is eplerenone. There's another one, finerenone, that it's in development right now, but it's costly. And also the newer kid on the block is SGLT2 inhibitors, which have proven to be a good medication across a spectrum of heart failure. So these are the fantastic four of heart failure. And it is important to know how to use these medications. And why are these medications important? Because they break the vicious cycle of heart failure. And by this, we mean the neurohormonal cycle that has been designed to help the body in acute situation, but because this activation continues over time, it's causing damage to the heart. Like in acute phases, when you lose, for example, blood volume, these mechanisms are designed to help the body survive. However, when you have reduced cardiac output, this triggers the kidney to try to absorb continuously salt and water, activates the sympathetic system, so you have a higher heart rate, and there is continuous hyperfiltration in the kidney, which causes also damage to the kidney. So what we are trying to do with these key medications, the cornerstone medications, is block important mechanisms that when continuing, they cause damage to the heart, to the kidney and the vessels, and they are causing heart failure to accelerate. So we try to stop this with this medication. And it's important to know what to do when. So this is a very nice paper, like from a couple of years ago. I'll try to explain that. So when the patient is admitted for heart failure, it is important to keep in mind that if the patient is on beta blockers, you don't discontinue the beta blockers. That would be a mistake. And also, if possible, if you can start medication like beta blockers while the patient is admitted, this is very important. Here's the reason why. The reason is that many physicians are afraid of starting beta blockers in a patient who has recently been hospitalized because they feel they may get decompensated, they may not tolerate it. So it's important for us, like we treat the patient in the hospital, to start the beta blocker if possible, and then start other classes of medication slowly and titrate. But this is important to keep in mind. Start at least beta blockers as a pillar, and then add one or two medications, keeping in mind the patient's blood pressure. As I said before, the sacubitril valsartan is a little bit more hypotensive, and if you diurese the patient too much, may not be able to tolerate that. And the same goes for SGLT2 inhibitors. It's an important class like of medications, but remember, they are still diuretics. So if you have diuresed the patient too much with loop diuretics, they may not be able to tolerate well because of the synergy. The patient will develop hypertension. So it's better to keep the patient on not on too much diuretics, so loop diuretics, so that you can start medications that are important to change the course of heart failure. The same applies to stable outpatients. If the patient hasn't started anything, that's in the bottom part, it's important to start the beta blocker right away because of immediate benefit and also prevention of arrhythmic events. So this is important. So if you can start a beta blocker and sacubitril valsartan, that is great. For patients who are already receiving these medications and are stable, you can add also an SGLT2 inhibitor, keeping in mind not to use too much loop diuretic because of the synergy, because then you want to add later a mineralocorticoid receptor antagonist. And keep in mind, all these are diuretics like loop, mineralocorticoid, and SGLT2 inhibitors acting at different parts like of the renal tubule. So you want to be careful about that. And this is the general recommendations from the American Heart Association, American College of Cardiology, what to do in patients who are at risk for heart failure. And obviously, these patients have to be treated with lifestyle risk factor modification. We take care of the individual risk factors. But when the patient has developed visible damage to the heart, it is important to start beta blockers and a renin-angiotensin system inhibitor early in the process. This is very important because this is where you stop the patient from becoming symptomatic, and the patient may go on for several years without developing symptoms if you catch heart failure at this stage, like you see the damage to the heart because, say, of previous myocardial infarction or hypertension that has been untreated, or the patient has received chemotherapy, or the patient has, unfortunately, like bad genes, has dilated cardiomyopathy. In the beginning, you see this, you start the medications, you're able to keep the patient asymptomatic for a long time. When the symptoms hit, then you have like two different trajectories depending on the patient's presentation and ejection fraction. As we mentioned, there are four pillars of HFrEF therapy, starting with beta blockers with diuretics as needed, but careful not to over-diurese the patient. And for those who have persistently reduced ejection fraction and they have indications for resynchronization therapy like wide QRS, for example, or left bundle branch morphology, then you may think about a biventricular pacemaker. And for those with persistently low ejection fraction who have a projected life expectancy over a year, then you want to think about implanting an ICD to prevent sudden cardiac death. I won't elaborate much from here, but for those who have persistently low ejection fraction, persistent symptoms, you might want to think about advanced heart failure therapies. And I realize that even in resource-rich settings, it is difficult for everyone to get a left ventricular assist device or to be considered for heart transplantation, which is a serious procedure with limited resources. Then you may want to talk to the patient and the family about palliative care. Now, I want to say a few things about the mildly reduced ejection fraction category. Although there is no strong evidence because there have been not many dedicated studies, it is my take, and I will say it loud and clear, treat these patients as HFrEF. So if you put in the totality of evidence that comes from sub-analysis from clinical trials that have included patients with borderline ejection fraction, or trial like that is usually trials with HFpEF that included patients with ejection fraction over 40%. If you look at sub-analysis of those trials with ACE inhibitors, with spironolactone, and now we have evidence also for SGLT2 inhibitors, and also for beta blockers, there have been meta-analysis. Everything shows the same direction. These medications do help patients with mid-range ejection fraction. So I'm going to say it loud and clear, treat mid-range ejection fraction as reduced ejection fraction because it is abnormal systolic function. The reason is that it is difficult to show benefit in these patients because if you have a borderline ejection fraction, you will need many more patients to demonstrate benefit with these medications. But if you look data on pathophysiology, neurohormonal activation, and benefit from the medications, these patients benefit all the same. So I would use exactly the same medications for my patients. Now, another important topic that people are asking about, what happens if the patient improves dramatically? What do? You do not stop the medications, especially the beta blockers. We don't have time to go through the many observational studies that tried to stop beta blockers and didn't work, but I will tell you a few important points to keep in mind. Patients who look now very normal on echo and have no symptoms, they still have a lot of changes at the myocardial level and at the cellular level. There have been super useful translational studies, both in mice and men, showing that no matter how improved the patient looks on the surface, there are important remaining persistent changes under the hood. That's why the patients are vulnerable. The experience, for example, from the Heart Syndrome Berlin, which is one of the largest centers for LVAD implantation in the world, even among patients who look like super normal, super perfect, after every test imaginable, a lot of these patients relapsed after explanting the LVAD and let them live freely again. So there's a lot of relapse. One trial tried to stop medications in patients who looked perfectly normal, trying to stop medication one by one. At 6 months, there was 36 relapse rate, like worsening of ejection fraction or clinical symptoms. So this is an important message. A patient who starts with reduced ejection fraction because of some etiology and looks as a super responder to therapy, keep the patient on therapy. There is no reason and no data at this point to stop heart failure therapy. So as I mentioned before, beta blockers are like a key medication in heart failure, and there are three beta blockers that are evidence-based in heart failure. Keep in mind, not every beta blocker is suitable for patients with heart failure. The ones that I have the evidence are metoprolol, carvedilol, and bisoprolol. In the European Union, nebivolol is also approved based on one trial that had borderline results. But the mostly used like beta blockers in the United States are metoprolol and carvedilol. And why is it important to start early and maintain these medications? A, because you have immediate benefit. You can see here, and I apologize, the arrows are not like spot on, but the curves separate very early because these agents have antiarrhythmic effects also. They stop life-threatening arrhythmias, and they also dramatically improve left ventricular remodeling. I was sharing a fun story before we start. I have been taking metoprolol myself because of cardiac surgery. And I left the operating room with very low ejection fraction, and I wasn't able to tolerate anything else than metoprolol in large doses. And my ejection fraction almost normalized like 6 months afterwards, basically just on metoprolol. So these agents protect from arrhythmias and cause dramatic improvement in remodeling. And you can see here that there is reduction in all-cause mortality, sudden cardiac death, and cardiovascular events down the road. They also protect from subsequent hospitalizations because of disease stabilization. And as you can see here, this is an excerpt from chapter 5 from our book on heart failure, written by an excellent pharmacologist from the University of Illinois in Chicago. You can see that there are important pharmacological differences in these agents. For example, metoprolol has very little renal elimination. And why is this important? Because sometimes we are afraid of administering or up-titrating medications in patients with severe renal dysfunction or on dialysis. This is a safe medication that you can use in these patients. And mind you that these patients are in fact at higher risk exactly because of renal disease. So I will stop here. I'll let Dr. Raghu take over. So this is my email for further questions. This is our book that provides additional insights that obviously we're not able to cover today, and I will be happy to take questions per Dr. Raghu's guidance afterwards. So thank you very much for listening.
Yes, sir. So thank you so much, sir. It was very insightful and it was a very summarizing also. So now Dr. Raghu sir will talk us on the Indian perspective and give his perspective also. So over to you.
Yeah. Thank you, Dr. Andreas, for a very succinct presentation on beta blockers and the overall management of heart failure. I would like to take this topic, presenting a few slides about the Indian perspective, and then go forward on the rest of the management of the heart failure. We take in the form of a question and answer. So can I share my screen, Pragatish, or what is the, let me see.
Yes, sir.
Yes, sir.
Yes, sir, you can share.
Okay. I'm sharing. And I can share. Is it seen now?
Yes, sir. Visible.
Okay, yeah. So I would present our audience a few slides about how heart failure is different in India versus the Western countries, and also provide Dr. Andreas a perspective. In India also, if we see Dr. Andreas, one of the first slides, the prevalence of heart failure is low as per the slide, but I think the prevalence of heart failure is as equivalent of that what we see in the Western countries. And then it's about 1% of the total population. I think it's definitely 1% of the total population. So if you see India being a very large is the largest, highest population country. So we have a large number of patients with heart failure in the country. And most of the time, as Dr. Andreas was pointing it out, the heart failure in India is because of large number of acute myocardial infarctions, what we see. And Indian heart failure patients are younger by the Western countries by about 10 years, or in fact, much lower. I see a lot of my heart failure patients post myocardial infarction in the age between 20 to 30 years also. So it's, if you see, out of the total number of heart failure patients across the world, about 50% of them are in India. So you can see the burden of heart failure is quite humongous in our country. We had a few registries in India which tried to look at the prevalence of heart failure in especially from Trivandrum Heart Failure Registry and Kerala Heart Failure Registry, and then the Heart Failure Society of India also did conduct one registry. So if you look at the heart failure registries, you see 75% of the heart failure is reduced ejection fraction with a 10% in hospital mortality, and all-cause mortality in the next few years is about 45%, which is quite huge. So that means there is a lot of scope for us to improve the outcomes what our people are experiencing now. And if you see those patients with reduced ejection fraction, about 75% of them have ischemic heart disease, and only 15% of them have got a dilated cardiomyopathy. So over the commonest cause of heart failure in the country, unfortunately, remains to be ischemic heart disease. And the older the person is there, the higher the risk of having heart failure. And they have the class of symptoms. If they worsen the class of symptoms, the higher the mortality, the higher the renal dysfunction, the patient is going to have a higher chance of mortality. So these are quite common. But what I would like to share with you is most of us have been taught the number that 50% mortality within 5 years in heart failure. But in India, we have much more than that 50%. We have about 60% even, right? Having said that, events like this and experts like Andreas help our physicians to develop confidence and how to start the therapies and all that in our patients. We have a lot of questions on the heart failure, Dr. Andreas. I thought that I will drive the question and answer with you rather than giving a didactic lecture about few slides, which is better and all that. So I would like to start with the question, and then later on we can take the questions from the audience. I thought that we have, first I would ask you a question on, we have got a lot of beta blockers in heart failure management. Uh, some people are fond of carvedilol, some people are fond of metoprolol, and some people are fond of bisoprolol. And even in metoprolol also, you have a extended release preparation and a plain tablet. So what do you take? Or what is which is the ideal beta blocker in a patient with heart failure? And how do we, which one you will give? And if you want to choose metoprolol.
So one important distinction to make here is that for metoprolol, it is important to use extended release medications, extended release formulations, because of a smoother pharmacological curve. Like you have a more even levels of drugs in the body, and this is important to keep in mind. It's important to keep in mind that the evidence-based metoprolol for heart failure is extended release metoprolol, not the older traditional, and this is because of smooth pharmacokinetics. I think obviously all evidence-based beta blockers in heart failure have their own merits. It's important to keep in mind that metoprolol is more neutral when it comes to blood pressure versus carvedilol, because it has an additional effect on blood pressure. So you have to keep that in mind. They both are easily titrated. I have personally less experience with bisoprolol, and it's not used that much. I believe in the United States, it's not used that much, and it's not used at least in our system. In Europe, they have more experience with bisoprolol, but in my take, it's metoprolol and carvedilol that are the most versatile depending on the patient's blood pressure, and have produced excellent results. And if you look also at real world studies, the outcomes are the same. Actually, a good friend of mine has done a meta-analysis a few years ago. So Alex Briasoulis, he's now like a professor in the University of Athens, and he has an excellent heart failure service. He has proven that in the real world use, metoprolol and carvedilol have about the same outcomes. So these are like my two go-to medications, depending on the patient's blood pressure.
So, Professor Andreas, you exhorted that we need to start the beta blockade in the hospitalized patients with heart failure. Obviously, hospitalized heart failure patients are those with acute heart failure. So, what are your tips for us to start beta blockade in the ICU? For example, we want to start a metoprolol. So, what is the initiating dose? How do we take it up further forward? Many times we are hesitant to start a metoprolol in our intensive care units.
So this depends on the formulations that are available. So when I was running a heart failure service in Greece for a while, and we had like IV metoprolol available. So it's good that you can use like an IV medication and simultaneously start an oral medication, so you can have acute effect. For example, especially if the patient has a high heart rate, uh, let alone rapid atrial fibrillation. This is where you immediately need it. But even with a high heart rate is a marker that you need something to stop the neurohormonal activation. And having a formula like an IV, small doses of IV that you can repeat as the longer term oral medication kicks in, it's a good combination. There are other beta blockers available, but I want to elaborate because that depends on what's available in your ICU. But this is an example, like giving a small acute dose IV and then the oral medication. So you combine these until you have stable effects, and you can track the heart rate, which is like almost like unmistakable indicator whether you're doing adequate beta blockade in the patient.
What's your target heart rate
Pardon?
in the ICU?
So,
What's your target heart rate?
so for the patient that has been stabilized, less than 70. And there is an additional medication that I didn't mention, that if the patient doesn't achieve that, you can start ivabradine in the outpatient setting. Like if you give the best you can do with beta blockers, and the best you can do here is questionable because sometimes we stop titration. For example, patient can tolerate metoprolol up to 200 milligrams, but sometimes we stop, which shouldn't be the case. If the patient that cannot tolerate any more from beta blocker and still has a high heart rate, you can add a medication that's specific to heart rate. But I would say the rate is below 70 if possible. Then you can be comfortable that you have stopped the sympathetic activation to the best of your ability. And there are population studies also showing that if you can achieve a heart rate in your body below 70, you live longer also. You know,
Yeah.
there are several anecdotes about that, but I won't go about that. But in patients in heart failure, it's a good target to keep it below 70. And in patients with atrial fibrillation, we used to be more strict, trying to keep it like uh, below 70 or below 90 when the patient is active. But now we have become more liberal because that didn't prove to have much benefit. So now if the patient is active below 110, is considered okay also in atrial fibrillation, because sometimes it's difficult like to strictly control, and it hasn't proved to have any benefit.
Dr. Andrea, you have been talking about ivabradine. In India, ivabradine is widely used, and then I see certain physicians start a ivabradine ahead of the beta blockade, hesitant to start on a beta blockade, and they feel comfortable putting them on ivabradine. What's your take on that?
I don't think this approach helps the patients that much, because the beta blocker is the medication that causes reverse remodeling. So if you want to see the heart improving, you have to give the beta blocker first. You have to titrate the beta blocker to the best of your ability, preferably in combination with at least one other medication. I haven't shown data that if you combine two medications, you have better results. If you're able to combine two medications, like a good beta blocker and say an ACE inhibitor. But ivabradine is after you have done everything you can do with the medications that actually stop or reverse remodeling, that improve the heart, and you only give ivabradine if the beta blocker cannot be tolerated, or you have maximized that and you still see high heart rate in the patient.
Okay. We have the door to needle time in ischemic heart disease. We have the door to diuretic time for acute heart failure. Do you propose that we have a door to beta blocker time in those patients with acute heart failure? You need to start the beta blocker early, or we need to wait for the patient to stabilize?
So I wouldn't propose like a door like to beta blocker time, and even the door to diuretic. Okay, it's okay. It's a little bit exaggerated concept that to demonstrate like the acuteness and the importance of heart failure. I would say it depends of the patient's hemodynamic status. So if the
Okay.
patient comes in like what we call, I didn't elaborate on that. If the patient comes in like wet and cold, for example, which means in cardiogenic shock, like it's not the time to give a beta blocker. You need to
Mhm.
maintain some perfusion, so you need actually to administer inotropes, diurese the patient, like very carefully place a pulmonary artery catheter, like to monitor hemodynamics. This is not the patient for a beta blocker. But if the patient comes in with ample blood pressure, with congestion and everything, so you have like a lot of blood pressure margin, then you can start beta blockers like pretty soon. If not like this, you can start even the next day. Actually, the sooner you start, the better you'll be able to titrate. And if you are like in rush to discharge the patient because you don't have, you need like turnover, you don't have bed capacity, it's better to start earlier because you will have a good sense where the patient stands at discharge, because it's not a good idea to not discharge the patient on the beta blocker. The reason is, as you mentioned before, the patient may never start the beta blocker because they
Yeah.
may go out in the community, a patient looks okay with diuretic and maybe an ACE inhibitor, and heart failure is a deceptive condition because the patient may look like pretty okay in terms of symptoms. But as I mentioned before, the underlying pathophysiological process moves forward. So the heart, if you don't administer all the medications you need to block the processes, the heart unfortunately keeps worsening under the hood. So after like 6 months or a year, the patient will come in and you will see on echo a worse heart than before. So that's why it is important for hospital clinicians to give the tone, like to provide to start with important therapies to give the tone for the patient's therapy in the long term.
Professor Andrea, what's the maximum dose of metoprolol what we should give? Because is it like an army where we should aim for a 200 milligram twice daily? Do you propose that we need to reach the maximum dose of metoprolol for our patient with HF,
So
or
if the
what the
patient,
patient can tolerate?
so there is a lot of evidence that more is better for most evidence-based medications. That includes beta blocker. But with beta blockade, we have heart rate as our guide. So if you are able to reduce like the patient's heart failure heart rate at rest like to 60 with 100 milligrams on metoprolol, it's fine. For me, this means that we have enough beta blockade, unless obviously the patient has chronotropic incompetence, like if the patient is too old and you suspect there is sinus rhythm disease and there is a different reason why the patient has a slow heart rate. But like in a younger patient who normally would have like a heart rate in the 80s and 90s, if you reach like a 55 to 60 at rest, then I would be comfortable and I would thinking about adding or increasing other medications to have synergy. But by all means, if you can achieve like max dose of metoprolol like 200, just go for it. So I would use
Okay.
both dose and heart rate as my guidance here.
Okay.
And
Last question
obviously,
from my last question from my end before we go to the audience questions. I thought there are, even though it is little out of the topic, we have a heart failure with preserved ejection fraction and those with reduced ejection fraction. You think beta blockers are a good choice in both the subgroups, or only for reduced ejection fraction?
so there has been a lot of talk on the basis of observational studies whether beta blockers may induce symptomatic worsening in HFpEF. it is my take that, especially in patients with hypertrophy, which is a major pathophysiologic component in many patients with HFpEF, beta blockers are important. And I will explain why beta blockers are important in this class of medication, in this class of patients. And this is where having detailed imaging, like a good echo, and if you can do like an MRI is important. I know it's more expensive and difficult, so I'll explain why is this important, like to know the exact pathophysiology. So many patients with hypertrophy have fibrosis in the heart, meaning if you do an MRI with contrast, you will see there are places of fibrosis. These are these are like focus points for arrhythmias, for life-threatening arrhythmias. So in these patients, for me, beta blocker is important. And if you look at studies trying to reduce left ventricular hypertrophy, beta blockers have produced excellent results, like reducing left ventricular mass by 1/3. So in this type of HFpEF patients, I would not pay attention to the symptoms, because sometimes the patient, I mean, remember the story with beta blockers when they started looking at beta blockers like 50 years ago. Initially, beta blockers were inducing symptomatic worsening because you reduce like cardiac output, like uh, for a while, until the heart improves, like has time to remodel and improve. So until I see like a good prospective study, I will still use beta blockers in most patients with HFpEF, along with other medications that have recently proven like to help these patients.
Thank you, Professor Andreas. Dr. Prakadesh.
Yes,
So I was sorry I took a little more, but we have 15 minutes for the audience questions and answers. You
yes,
can take it forward from there. Yeah.
absolutely, sir. It was pleasure to get the insights from both of you in a question and answer way. So it was so insightful, and we have few questions from the audience already posted in the chat box, which I will be able to moderate. Sir, one specific condition or a scenario-wise question has come. The question is from Jammu and Kashmir from a doctor. So he's asking patient admitted in emergency with acute heart failure with with conduction defects. So in this case, what is your advice, and can we initiate beta blocker?
This is an excellent question. So obviously, if the patient has like conduction disorders, you don't initiate beta blockers until you see what's going on with the patient, whether there are reversible factors like electrolyte abnormalities or any like acute toxicity from any agent. So you would like to see the patient stabilized first from that perspective, and then if the patient has persisting like conduction abnormalities, then one potential way to move forward, obviously, you cannot start the beta blocker in these patients without protecting the patient. One potential approach, if the patient needs like the medications, and there are many patients who do, is to place a pacemaker to protect the patient and also initiate a beta blocker at a second stage. The reason is that the patient still needs medications that will improve the heart and beta blockers and also prevent from life-threatening arrhythmias. So beta blockers are a pillar of therapy. So if the patient needs a pacemaker for conduction disorders, you place the pacemaker and you start the beta blocker. You don't keep the patient off beta blockers and, follow a see what happens approach, because chances are the patient will still need the pacemaker anyways, and will still need the beta blocker.
Yeah.
Right.
I would like to add, Dr. Prakatish, there is a lot of misconcept amongst clinicians that beta blockers are responsible for AV block, conduction block, and all that. But the true problem is many of these patients have got an underlying conduction system disorder. What we attribute it to beta blocker might in spite is not due to that. It is basically due to a conduction system problem. So, as Dr. Andreas is telling, most of those patients who have got a conduction system blockade, I think, eventually need a pacemaker. And my take on this is better put the pacemaker early rather than wait for the true indications of the pacemaker what are there in the textbook, because many of the time it's not this patient is going to need a pacemaker, if not today, a couple of months later. Better put it early. That's what I would suggest my patient.
Oh, Raghu, I remember when I was in training in the 2000s, because we had like to wait for the medications to wean off completely to get approval to insert a pacemaker. We were waiting for days. I cannot remember a patient who really didn't get a pacemaker
Yes,
either immediately or the
yes,
patient will come back with syncope like a couple of months
yes,
later.
yes,
So
yes,
most of the time, it's not like the beta blocker that is causing like or aggravating the heart block. So it's better like to treat the patient acutely. I understand you have acute heart failure. You treat the patient. You wait to see for important other abnormalities to go away. But I have a very low threshold in implanting a pacemaker and starting the
yes.
patient with beta blocker.
Yeah.
Okay, sir. So there is another specific question. As Raghu sir, you have also mentioned about the adverse event concern about the beta blockers. So they are asking in young patients, what are the strategies to overcome this beta blocker induced fatigue, or maybe to the extreme like impotence in young patients. So is it so encountered in our patients, or if so, then any strategies to follow on?
Sorry, I didn't get. Sorry, there was like a drop in the sound.
I will explain you, Professor Andrea. If we start the patient on beta blockade in an young person, the person can experience fatigue and the person can possibly experience impotence. So,
Mhm.
how do we manage these two scenarios of weakness and impotence?
So there have been studies about this. In several studies, uh, the fatigue and ED are like the same as with placebo. So sometimes,
Yeah.
the sense that, oh, I'm taking a beta blocker. So causes you to think that I'm taking like a medication that causes impotence or like causes fatigues and you feel fatigue. So so if the patient experiences those symptoms, you can try reducing the dose, but I would never stop the dose, especially in the young patient. Now, this is an important question because the young patient has many years ahead of them. So in a French study, they stopped the beta blocker several years after the patient like had normalized ejection fraction. That was an observational study, not randomized. That's why I didn't show it. Well, a lot of patients like the cardiac function went down. And to put it otherwise, it's unlikely that the patient's erectile dysfunction will become better if the heart function becomes worse. You know what I'm saying? Because is important. So I would encourage the patient to continue, maybe try reducing the dose a little bit to see how the patient goes. But I would do my best to keep the patient on the medication, keeping in mind that these side effects are kind of subjective and sometimes are placebo effect. There was a study in Norway several years ago with beta blockers showing that exactly the same rates of fatigue and erectile dysfunction with placebo and beta blocker. So I haven't delved into that, but I could encourage our colleagues to keep the patient on the medication, trying various scenarios, but keep the patient on the medication.
Sir, questions to both of you, especially Dr. Raghu sir. Sir, in terms of patient profile, or maybe you have told that we have heart failure much a decade ago from the Western things. So, from your experience and also from Andrew sir's your experience, so which beta blocker is again like mostly used or specific patient profile, may it be metoprolol or compared to bisoprolol or carvedilol? So, which is placement therapy is much better or much tolerated? So, in that, your views, sir.
Yeah. Dr. Pragatish, for patients with heart failure, as Dr. Andrea is telling, we have two options, either metoprolol or carvedilol. But I prefer a metoprolol because of its ease of use, once a day, more predictable effect, and I know this is a quite commonly used drug. So my choice would be a metoprolol. We can give it for those patients who have a borderline renal dysfunction. Most of the patients, quite a few, not most, but a lot of patients in India with acute heart failure have got some degree of renal dysfunction, creatinine borderline elevated. In that scenario, also a metoprolol is preferred. Then coming to the specific setups of young people having heart failure, and choice of a beta blockade. I think once again, metoprolol scores over the other groups. The ease of use once a day is one of the important things why a metoprolol is preferred by me personally in my practice.
So there's
Yes.
another consideration. Sorry, go ahead.
No, sir.
Dr. Prati, please.
Sir, in terms of dose titration, also you find metoprolol to be most effective, sir?
Yeah, we can, I did not have an opportunity to go to 200 milligrams. That's why I was asking Professor Andreas what's the dose what he keeps trying. But I go up to 100 milligrams, and we can go easily up to 100 milligrams without any challenge, even in a small person of the Indian this one. Whereas the same thing, one of the reasons why, because you brought another point is, for example, if I want to achieve 25 milligrams of carvedilol, I have to give 12.5 or 25 milligrams twice daily of carvedilol. It takes a long time. Whereas here I quickly up titrate my dose 25, 50, and 100 in a period of about 4 to 6 weeks time.
Fine.
So I would like to bring forward also another consideration. Uh, the data, the comparative data on metoprolol versus carvedilol and whatnot, were mostly before the era of sacubitril valsartan and SGLT2 inhibitors. And this is important because both sacubitril valsartan is more hypotensive than ACE inhibitors or beta blockers, and SGLT2 inhibitors have also a slight but
Yes.
important hypotensive effect. So in today's environment, we will try to give 4 therapies plus the MRAs, which are known to have also hypotensive effects. I mean, this metoprolol might help the patient tolerate more of the other medications, which now we know it's important to tolerate more classes. So there are no prospective studies, and this might be a good reason to think of metoprolol here as your first pillar, because it gives you ample room in a patient who has like borderline blood pressure, as in the Pioneer HF trial with sacubitril valsartan. So in this case, I would rather have a beta blocker that gives me more margin with other medications.
Okay, sir. Sir, since you mentioned about MRAs also, there is one question from the audience. So, which MRA should you prefer, especially in reduced ejection fraction, sir?
So the most data are with spironolactone. The downsides is that it's causing gynecomastia and sometimes has like hormone effects. It's not very common, but exists. I would start with spironolactone, and maybe if the patient experiences hormonal side effects, you can switch to a Pleuronon. Like in my book, these are equivalent. There is another agent that it's non-steroidal that's coming. It's Finerenone, but currently the cost, because it's not generic. The other spironolactone has been generic for 100 years. So a Pleuronon by now, I believe it's generic all over the world. Finerenone has a non-steroidal structure, so it doesn't have hormonal side effects and the same hyperkalemic effects, but it's way too expensive. So to summarize, spironolactone, if the patient experiences side effects, a Pleuronon.
I have one more additional point, Dr. Pragatish. Like
Yes.
for those patients, as per the guidelines, the maximum dose of spironolactone, Professor Andreas can correct me, is 25 milligrams. Whereas eplerenone, you can up titrate to 50 milligrams. Professor Andrea, what is this your take? You can go up or
You
what's
can.
it?
So I agree with this approach. You can use like spironolactone up to 50. It has been tested both in HFpEF and in HFrEF. So it is, I mean, you don't have additional issues. And this is true, as you mentioned before, with beta blockers. Doesn't mean that because you go from 100 to 200 that it's double the effect, that you have like a huge reduction in heart rate or blood pressure or anything. So it doesn't go like proportionally. And the same goes for spironolactone also. You can increase the dose. 25 is a very effective dose. You can go with both agents, Spiron and Pleuronon. You can go up to 50. That has been tried in clinical trials.
Okay.
The patient is going to be okay.
Okay.
Yes, sir. Sir, I think this is the final question, sir. Sir, on the effect of extra, apart from the heart failure, like lipid lowering therapy, we are getting articles, small studies on the extra effects apart from the cardiac heart failure things. So your perspective on which bitoprolol is much better in these conditions and also especially in CKD patients.
Regarding the lipid profile.
Yeah,
It's a
dyslipidemia and
lipid
which
profile and
blockade.
yes, sir.
So I'm not an expert like in lipid profile, so I won't directly address these questions. I would say, though, that India, one of the reasons in India you have higher mortality, I believe that you have much higher proportion of ischemic heart disease as underlying etiology, higher than elsewhere like in the world. And we know that ischemic heart disease is more difficult to treat because you have scars, you have issues that are not reversible. That's why it's associated with high mortality. And for these patients, like the lipid profile is very important because you have to optimize the coronary artery disease profile also. But I will defer that question to Dr. Raghu.
It's tough for me even to answer, Pragadish. I'm
Yes.
not sure whether it's the answer which beta blocker for dyslipidemia. I'm not sure, but
For on
yeah.
CKD, sir.
Yeah, chronic kidney disease, Dr. Andreas has shown very clearly in his table from his own textbook, showing that metoprolol has got a very low renal excretion.
Right.
So you don't need a dose modification for metoprolol compared to that of the other agent like the carvedilol or even bisoprolol also, you need to modify the dose of the drug. So if you see the cardioselective beta blockers, metoprolol does not need a dose reduction in renal dysfunction. That's why it is all my nephrology friends choose a metoprolol compared to the other beta blockers over and above the other beta blockers.
Yes. Yes. Thank you. Thank you so much, sir. So, as we conclude our webinar of essential heart failure, a special perspective, firstly, heartfelt thank to our esteemed speakers, Dr. Andrews, sir, and also Dr. Raghu, sir. Your comprehensive insights and expertise have significantly enriched our understanding in the critical role of beta blockers in heart failure management, especially understanding the Indian perspective also, and from the studies and the guidelines from Andrews, sir. So, we also want to express our appreciation for our dedicated audience today, medical professionals who are attending, actively participating, and putting forward the thoughtful questions to have a greater enhanced discussion. And I am personally thanking my medical team and also the Sun Pharma team who are behind working for all this to put forward all these webinars, and hope we will have such a insightful webinars for the educational purpose in the future events also. So it's thank you so much, sir, and thank you once again for both of you contributing significantly and clearing all of our doubts. So have a great day, sir. Thank you, everyone.
Thank you. Good night, everyone. Have a nice weekend.
Yes, sir. Thank you.
So with the permission, shall we go offline?
Yes.
Yeah. So we are going offline. Just a moment.